Did you know that 5 in 10 concussions go unreported or undetected? Stay tuned because today you will discover what tests to perform with concussed patients and what tests to perform for return to play. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain based solutions to help your patients recover from head and neck injuries and improve neurologic function. I'm honored to welcome our next guest expert. Dr. David Traster is a chiropractic neurologist with a master's degree in sports health science. He's an assistant professor for the Carrick Institute for Graduate Studies. He's a co-owner of the Neurologic Wellness Institute, which has 4 clinics located in Florida, Illinois, and Wisconsin. Dr. Traster specializes in neurological rehabilitation, which includes traumatic brain injuries, dizziness, dysautonomia, chronic pain, migraines, movement disorders, and more. Today, he'll be sharing with us assessing and monitoring your concussion patient. Dr. Traster, thank you so much for joining us on the Virtual Neurology Summit. Please take it away.
My talk today is about concussion and what you can do to assess your patient. My assumption is if you rolled your ankle, had an ankle injury, you would want somebody that knew something about the ankle. Maybe the anatomy, maybe the physiology, maybe some therapies or exercises or some assessments to look at the ankle. I'll make the argument that most people in society that claim that treat concussions really do not know much about the brain. And it puts society in a little bit of a complex because people could know some good assessments or treatments for people who have concussions. For example, concussions are associated with neck pain or whiplash injuries, possibly. And there's a lot of people that treat the neck who could help a lot of people with concussions. But the question is, if they don't know a lot about the brain, are they missing a red flag? Are they missing physiology or underlying causes of symptoms? Are they treating the whole picture? Or are they helping with symptoms? Or for each patient, it might be different. For one patient, it might fix 100% of the problem, and another patient, that might make it worse. And so I would first make the argument that you want somebody who deals with the brain that understands it, right? And that's obviously a problem in education right now because the highest trained people classically in neurology do surgery, right? And they're not necessarily the people for concussions. When you look at medical neurology, although people obviously deal with concussions and the research looks more at exercise, and exercise is not necessarily the most profitable area of medicine. And as a consequence, you don't necessarily always get the brightest. And most people don't even know what a physiatrist is or know a physiatrist, which would be a medical doctor that specializes in physical medicine, right? And so it's a little bit of like a dark cloud in medicine, but these are the people that probably should be trained the best to help people. And so when you look at the brain's complicated. We don't know a lot about the brain, right? And so it puts another problem as far as how to assess the brain, how to understand the brain, how to treat the brain. But in the big picture, we could separate the brain into 3 categories. We could separate the brain into like a perceptual category, meaning what you're feeling, what's touching you, what you're seeing, what you're hearing, kind of your perception of your body and the environment. You can separate the brain into like a movement category. And you're going to move either scale. At the end of the day, your brain can only do one thing, and it can contract muscles. That's really all it can do. And whether it's a vocal cord or whether it's a smooth muscle or a skeletal muscle, that's how your brain operates. And so when we look at movement, we want to look at skeletal muscle. How do you move the muscles on your bones? We also want to look at smooth muscle. How do you move, different aspects of hormones or your blood or your heart or your digestive system? And these are all movement aspects of the body and of the brain. And then the third thing is more humanistic aspects. We want to look at, memory, cognition, emotionality, and these aspects. And by putting it all together, these all work together and allow us to be human. And so the whole thing is with the brain injury, anything could be injured. And so if you're going to a physical therapist or a chiropractor or someone who's special, an acupuncturist, a massage therapist, someone who really specializes in movement, the question becomes is how well can they look at the big picture of your injury and how suited are their therapies for you with your condition, right? And I can't tell you what it is, but what I can tell you is the training is very isolated to muscles in general. And then there's exceptions to certain people who go to a higher level of education. If you're going to go to a psychologist or psychiatrist, and there's a higher probability you might be diagnosed with anxiety or PTSD than post-concussion. right? And that's their wheelhouse, but they might never listen to your heart. I just had a patient 9 months post-concussion she was diagnosed with anxiety and panic disorder and conversion disorder, like she's making it up. And she had an arrhythmia. No one listened to her heart for 9 months. Right. And she went to many medical neurologists and no one listened to her heart. And as a chiropractor, I could listen to her heart for 1 second and see here the arrhythmias and send her EKG right away. And so again, like, what is your specialty and how are you viewing the person? If someone has a family history of heart condition, which this person did, you would think that somebody would look at the history and say, maybe we should run an EKG, right? But they ran CTs, MRIs, caloric testing, VNGs, all types of testing, and they diagnosed her with anxiety, even though, arrhythmias can cause anxiety, right? So they diagnosed her with an exclusional diagnosis, even though they didn't exclude everything, and they missed a big thing. So if you go to a psychiatrist, which we love psychology, psychiatry, mental health, but are they the best people to deal with movement problems or sensory problems? Maybe not. And then when you look at sensory problems, who do we have in society that really deal with that? And I think that's where physical medicine is getting better. But when you look at people who have sensory issues, you're typically looking at neurologists that diagnose neuropathies, right? And you're looking at nerve problems. You're not necessarily looking at perceptual brain issues, right? And so from those three alone, I think you could see we're starting to have an issue, because let's just talk about the perception. As a concussion, you could have a visual problem from a concussion, right? Your eyes could be perfectly fine. It might have nothing to do with your eyes. It could be all vision. And you can have a visual perceptual problem. You could start seeing your mom and not recognizing her mom, but hearing her voice and knowing her voice, right? You could start knowing all different conditions. It's all perception. You can get dizziness, visual perceptual issues. You can get PPPD. You can get certain conditions like a vestibular migraine or Maladita-Barkman syndrome that give you visual motion and false sense of motion. You can be motion sensitive, right? And you could just get any type of motion that goes in your vision. You can get nauseous. You could have hearing problems. How many concussions have tinnitus, right? And so the first person, you go to optometrist, go to ophthalmologist, what are they going to do? They're going to look at your eyes and they'll say everything's fine, right? Most likely, unless there's something that's not fine, right? But they're not necessarily, in general, the people that are going to be treating the brain, although there's more optometrists that are getting into more rehab, right? You then look at audiology, you get tinnitus, or maybe even hearing loss, but definitely tinnitus, you go to an audiologist or an ENT, right? And they're going to look at you, maybe they match the tone of the tinnitus, maybe they give you some tone matching exercises, but that's pretty much what they got for you. If you got dizziness, you might go to the ENT or maybe an audiologist, right? And they're going to do some inner ear testing. But if it's not an inner ear, which probably not, outside of maybe BPPV, which hopefully they diagnose correctly, what are they going to do? Right? They're going to tell you the inner ear is fine, and they're going to kick you back to the neurologist, who is most likely is going to diagnose you with post-concussion or vestibular migraine or PPPD if you're dizzy. And then where does that fit you, right? Because vestibular rehab is a little more geared to inner ear disorders. And so if you're dizzy with concussions, you're in a little bit of a tough spot, because there's not many vestibular specialists that deal with the brain, although there's becoming more, because it's getting better, but you're still in a little bit of a problem. If you look at your proprioceptive system, this is where there's a lot of people that are trained to help people, but they're trained in the wrong way. Because if you look at the proprioceptive system, your muscle movement's really secondary to brain activity. What's really primary about your muscles is the feedback into your brain and telling your brain where you are in space to allow your brain to know where the muscles are to allow them to contract, right? And you can either eccentric, isometric, concentrically contract muscles to allow you to move. But most people that are trained on movement and muscle function are trained on the motor aspect, not the sensory aspect, right? And so then it comes down to, although massage, acupuncture, chiropractic, PT is amazing, how amazing is it if you constantly compensate for someone because of a sensory problem and you're just keep compensating for movement issues, right? And so that's a big deal, because some people have pain syndromes, which is a sensory problem, right? Some people can't feel one side of their body, right? They have a neglect syndrome. And some people could have all types of pins and needles feeling or heaviness feeling, etc. And so this is just some basic sensations. Some people lose their smell or get smell sensitive, right? Some people lose their taste or taste things that aren't there. Some people hear voices that aren't there. We've got a patient today who's hearing voices in her head after concussion, and that shouldn't happen, right? And so these are all perceptual issues that typically live in more your perceptual parts of your brain, which most people think is the parietal lobe. Although there's an insular cortex, and there's all different areas, subcortical areas that deal with this. But from a cortical level, we're going to say the parietal lobe has a lot to do with sensation. We then can have movement problems, right? You can have dystonia where muscles are contracting too much and you got like cramping, in the big picture. It's not cramping, but you can almost think of it like your muscles getting stuck. You can get tremors where people shake, right? The rate of Parkinson's can go up for some people after a concussion. So you could look at shaking and tremors. You could look at myoclonus. You could have seizures, right? And movement disorders as far as seizures. And so you really want to look at these movement disorders and understand the muscle is not the problem. It's the brain that controls the muscle, which once again, some of these conditions like there's complex regional pain syndrome, which is perceptual, whether it's dystonia, which is more movement, sometimes treating the body part that hurts or has a problem is the worst thing you could do, and it spreads. And so you've got to be careful as far as who's trained on this, because if you've got a stroke and they're stretching your arm all the time, it might not be as effective as treating the brain versus the muscle, right? And so when you look at movement disorders, you're looking at more neurological disorders affecting muscles, and by treating the muscle, it may or may not work out in your favor. Other parts of movement disorders, you look at autonomics, right? And so you got to look at, do you have adequate blood pressure, both in your body and in your brain? Does your blood pressure stabilize when you move positions, lying, standing, seated? What's your heart rate variability like? Does it change to deep breathing? What's your Valsalva like? Do you have appropriate brainstem autonomic reflexes where you're getting appropriate parasympathetic and sympathetic tone to allow you to adjust the world? Right? These are all things that you can look at and say, is there a movement problem going to your arteries? And then finally, you can look at like cognition, emotion. Do you have anxiety? Do you have PTSD? Do you have fear? How are you sleeping? Do you have memory problems and these type of things? Before with movement, we obviously look at walking and gait. You have changes in your walking. Do you have changes in your gait? How do these interplay? And then when you look at all of that, you start to ask, who's trained in all this? Right. And there's a few people trained in all this, but it takes a lot of time and it's not classic education, because the neurologist might be trained in one thing, the psychologist is trained in another thing, the psychiatrist is trained in another thing, the massage therapist, the physical therapist, the chiropractor. At some point, how many doctors can you see? And is it reasonable to see that many people? And so in the big picture, you can see where we're in a little bit of trouble as far as how to manage these cases, because from a classic education perspective, we've isolated and specialized at such a high level, and the brain controls everything. Embryologically, you start with the nervous system and everything branches out, and you never lose those branches in communication. And so everything is a consequence of brain activity. It just depends, is it more things are firing into the brain inappropriately? Is the brain processing inappropriately? Or are you getting inappropriate output to the brain causing problems? But either way, those are kind of your options. And how does the brain integrate your environment, and how does it relate? You obviously have aspects of inflammation, you have aspects of oxidative stress, you have aspects of all different metabolic things, but those are all secondary to a physical injury unless your previous health status was less than normal before the injury. And if it is, which a lot of people's it is, you have other issues, right? Because when you look at a concussion, rule number concussion is, what was your health before the concussion? What were the details of the head injury? And what did you do since the concussion? Right. And so everyone's at a different starting point based on their genetics and their environmental exposure. And everyone's concussion is different. And so no two concussions are the same, which makes analyzing concussions different and difficult. So what do we do? At our clinic, what we do is we do a few things. So and then we'll go to the Q&A probably, because we're probably, getting close to that once I'm done with this. But when you look at what we do for an assessment, and this doesn't mean you have to do this, but this is just from our perspective, what we do. The first thing we do is we do a QEEG test, and we like to look at brainwave assessments to look at more functional scans that deals in more activity, and it's a little more cost effective than an fMRI or SPECT or FNIRS. So they're all great in their own way, but we use a QEEG. We then do evoked potential testing, right? We do auditory evoked potential, we do cognitive evoked potentials, we do visual evoked potentials. And what we want to do is say, when we stimulate a receptor of your nervous system, how fast and how strong does it integrate in your brain? We know with concussions, one of the first things that happens is you might function okay, but different parts of your brain might be controlling it now. And so your control centers could change. So if you're not looking at evoked potentials and just looking at functional output, you're missing something. And so what we want to do is we want to give you functional testing, but we want to then read your brain while you do it and say, are you incorporating the correct parts of your brain, or have you been concussed and are you compensating? Because then we could do therapies to force the correct parts of the brain to start working with the right functions. And so we're able to look at QEEG testing, evoked potential testing, and get a little more of an electrophysiological look at the brain. We then can go in and we do our cognitive testing. We look at memory testing, attention, awareness, reaction time, dual tasking. and we try to understand a little more functionally how your cognition, how your memory is doing, how your attention's doing. We then go and we do a full eye movement assessment. Actually, no, next we do autonomic assessment. So we're going to look at your heart rate. We're going to look at your respiration rate. We're going to look at your blood pressure live. We're going to look at your heart rate variability. We're going to look at your cerebral blood flow in your brain, as well as your blood pressure in your body. And we're going to look at these factors while you breathe, looking at heart rate variability. We're going to look at this on a tilt table test to look at your orthostatic aspects. We're going to look at this with Valsalva to look at mechanisms with brainstem reflexes. We're going to look at pseudomotor testing to look if you have any peripheral neuropathies, if you have any sweating issues because of a nerve issue. And we're going to get a good readout about your autonomic nervous system. We're then going to go and do a full eye movement assessment, and we're going to record tons of eye movements, both in dark and light, to have a good idea of how your brain now is controlling your eyeball and what kind of areas affect your vision from your eyes and your brain. We then do a full balance test, and we're going to look at a full balance test on foam pads, on firm status, on station, on eyes open, eyes closed, different head positions. We then do a full visual assessment, and we do about, I want to say it's 10 tests, 10 visual tests, and each one's a different part of the brain, right? So it's not an eye test, it's not a Snellen chart, it's different visual tests that each incorporate different parts of their brain as control centers. So can you track multiple things at once? Can you see really quickly what, your abstract kind of sensory vision? So like, we look at little like squiggles and they're pretty light versus darker. So, how sensitive is your vision? Can you look really quickly and see a target that pops up really quick? What's your reaction time? So we have all these different visual tests or depth perception that we do. And then we do a full neurological examination, cranial nerve testing, sensory testing, motor testing, all the testing we did, but then we do it at bedside. And really by the end of that, that's about, I don't know, 3-4 hours. You're looking at about 4 hours of testing. And then that's when we start. Right, after about 4 hours of testing, we're able to start saying for this person, this is how their nervous system is today. And after all that, the worst thing about concussions is you just spent all that time to know how your brain's doing. You don't have a baseline. Right. And so we really don't know for most people, like, we do a lot of professional athletes and high level athletes. These people have been hanging out with trainers and personal trainers and athletic trainers their whole life. They've never once had a brain test outside impact test, which we can talk in another time, whether that's even a valid test on its own. But the fact of the matter is no one has any baseline. So then we have to look at it and say, this is where you are today. And we have to kind of take the best guesstimate of where you were before your concussion, assuming you probably already had one before. You might have had 2 or 3, one as a kid. And so the data is limited. The baselines are limited. The biomarkers for brain are limited. And even the ones that we're using in our clinic, we're still not sure which is the best and most specific or sensitive. So we try to do as many as we can to get as much information as we can to then do therapy specific for each patient. When you look at the difference between what clinics like ours do and other people do, I'd argue most people don't assess people. I think the majority of healthcare has a diagnosis problem. And I think majority of healthcare is improperly diagnosing people based on insurance standards and not based on physiology. And I think it leads to improper treatments. And I think concussion is a classic example where even if you diagnose it correctly, it doesn't translate into a drug or a medication or supplement. All right. It doesn't mean fish oil is not good. It doesn't mean vitamin D is not good. It doesn't mean creatine is not good. It doesn't mean other things aren't good. But the fact of the matter is the human research is limited. The human brain is different than a rat. And we know over and over again that things that work with rats don't work with humans a lot of times, right? And so a lot of people are taking great brain health supplements, and I'm all for healthy brains. But because you take a healthy brain supplement doesn't mean it's going to fix your brain condition. And what I find more so is people doing healthy brain advice, especially on social media, and thinking that healthy brain advice is going to treat a brain disorder. And what healthy brain advice does is hopefully make you healthier. All right. But when you get an injury, you got to treat it specifically. Like you don't roll your ankle and take a multivitamin. You know what I mean? Like it doesn't, like I get the perspective, but it really, when you think about it, it doesn't make any sense. And it's really miseducation starting at the highest level of PhDs, medical doctors, PTs, chiro professionals in general with the education, because we're educated in a way that's not really great for concussions. And we just cross our fingers and hope that by treating your body or giving you a drug, you're going to feel better. But you might feel better, but 20 years later, you might have a memory problem. Right. And so it becomes a tricky thing. And that's kind of where we're at in society. This is why we need more research. We need more data. We need more understanding of the brain. We need more tests like I'm talking about. Every test I talked about is objective medical tests, right? That's subjective. You got a number to it. There's nothing fancy about it as far as like I can't fix the numbers. I can't cheat the system, right? There's nothing slick about it. It's just, and it gives me a way as a chiropractor to communicate with the highest level neurologists, which I do, professional athletes and teams. I'm seen as a visual vestibular specialist, and I could talk to anybody in the world about the brain, and I might not know as much as someone. I might more than the next person, but I could sit at the table and have a communication where I'm not getting laughed off the table. And I'd make the argument where we started. Most people, in my opinion, that treat concussions will be laughed off the table with PhDs because they don't understand the brain, and what they're saying on their advertising, marketing, and social media is vehemently incorrect. And they can still help people though, which makes it confusing because their therapies can still help. But the bigger picture, if you could understand the brain, you could understand the red flags, you could do it quicker. And it's not about symptoms. You can get rid of symptoms a lot of ways. Just getting rid of symptoms doesn't mean it's brain healthy. Taking morphine can get rid of your pain. It's not a healthy thing for your brain, right? I could do a lot of things to help with symptoms, but if 10 years from now, I just compensate you, and 10 years from now, you end up being dizzy, or you tap your head and get concussed again, or you end up having a memory problem, then how well is my 10 years of numbing you so you don't feel the problems you have? And that's what we see in society a lot of times. That you get concussed and you either get better by yourself or someone treats you, but they didn't really fix it. They kind of numbed your symptoms, and the pathology is still there. And it's not till the next concussion or pregnancy or a fall or a virus or whatever it may be comes in. And then all of a sudden these things just blow up. And that's what you're seeing a lot of times that we've seen with all these viral issues, especially recently. It's a lot of times it's not a new thing. It's things people have had their life, and now it's just way worse. So it just like exacerbated. So if you were a post-concussion patient, never treated your concussion, symptoms went away, and then you catch a flu or COVID or something, and all these symptoms you had after concussion came back, there's a chance that you might have never fully healed. All right. And you might just compensated just from naturally compensating, but you never might have got the right areas or the correct areas of the brain to fire when they should. And you were using the wrong control centers until eventually those things broke down. You couldn't compensate anymore.
I think the perfect example is if you hurt your ankle, you need to see somebody who understands the ankle, and the same being true, and even perhaps most importantly with the brain. So learn about the brain for best care, must understand brain education. And the brain is complicated, but ultimately there's three categories from which to begin. So there's perceptual, feeling, touching, seeing, hearing; movement, which is muscle contraction of skeletal and smooth muscle; and humanistic, memory, cognition, personality, and emotions. And people who specialize in movement tend to focus on movement. A psychiatrist who focuses on diagnosing PTSD will likely find PTSD problems, right? Or will likely more likely diagnose PTSD post-concussion. So it's recognizing where we have our level of expertise and not only seeing that, but also understanding the brain for patients who have a mild traumatic brain injury, such as a concussion. And ultimately, who deals with sensory. So we need to find better ways of dealing with sensory input, because ultimately sensory input drives brain reactivity. And concussion can lead to visual problems, having a visual perceptual problem, dizziness, vestibular migraine, motion sensitivity, hearing problems, tinnitus, smell sensitivities, taste sensitivity, shaking, tremors, and many others. And so it's important to remember that each person has their individual case presentation. You talked about proprioceptive. So movement is secondary to sensory. Sensory activation tells you where your body is in space and to know how and where to move. We talked about cortical, parietal being for somatosensory, and movement disorders. It's not the muscle, it's the brain that controls the muscle that has inadequate activation. And autonomic, so doing adequate blood pressure in the body and the brain, HRV, Valsalva, brainstem, autonomic reflexes. And then, of course, considering cognition and emotion, walking and gait. And embryologically, starting with the nervous system, all those connections created originally, and then that becomes how we perceive our world. So everything begins with the nervous system, it creates the connections, and then this is how we perceive, understand, and integrate our world in order to function within it. So when it comes to assessments, you started with QEEG, which is brainwave assessments; evoked potential testing. So when evoked, how are they responding? And it's really about reading the brain during functional testing. Cognitive, doing things like memory, attention, and dual tasking. Autonomic, heart rate, respiration rate, HRV, tilt table test for orthostatic and Valsalva, and then brainstem reflexes, peripheral neuropathies. And eye movement assessments, 10 different visual assessments, which is actually testing the brain, the different parts of the brain that control eye movements, and balance tests on foam pads on firm surface, eyes open, eyes closed, different positions of the head, and then doing a full neuro exam, such as cranial nerve, sensory, and motor. And this is about 4 hours of testing. And so then that determines where are they today. And unfortunately, we don't know. In many cases, we don't have a baseline to compare to. Baselines become limited. And so healthcare has a diagnosis problem. I thought that was very well stated, leading to improper treatments. And health supplements, health supplements are good, but you still need to correct the disorder or still correct the brain problem. And that really comes down to objective medical testing. And lack of symptoms does not mean it's a healthy brain. So for many concussed patients, they get better on their own, or they can numb their symptoms long enough to then return to play or return to work. But it doesn't mean that their brain was fixed in the process. So a couple questions for you. After you doing your neurologic test and, you explained all the parts that you're going through with the brain, which is phenomenal. Thank you for sharing that with us. Would you then do a full reassessment with all the same tests for return to play? Or what would be your main differentiator allowing them to then return to play or return to work or return to their activities?
Yeah, we run the same exact thing. The only thing I didn't mention, which we run, is like a buffalo treadmill test, like some type of cardio, some type of exercise test, especially with athletes, that we would run and get a metric on, their exercise intolerance or when their symptoms would spike. So we would run that. But from our perspective, our job is to work with like for example, we had a professional baseball player here the other week who had a vestibular issue. What my role is on the team. I'm not the team AT. I'm not the head medical doctor on the team. What my role is to give them feedback as a specialist to say when they're safe to return to baseball activity. Right. And that's where I come in, right? I'm not there to tell them when they're ready to get back in the game. I'm there to say, when are you ready to safely participate in baseball activity where the coaches can do what they do, right? The trainers can do what they do, because right now you're in a position where all the staff doesn't know what to do with you. Right. And so it's my job to get them back to that point. So what my job is to create objective measurements that correlate to your problem. And when those objective measurements correlate and they get better, I could then be in a position to say you are now functioning at a level where you're safe to play. And now you're safe to play. We've got to get you back conditioned, because a lot of times people are deconditioned, their reaction time's slower. So we just got to get them back practicing. And so, but for sure, we're going to do is we're going to run all the same tests, because we're treating off those tests. And so what we would expect are those tests to change and improve if our therapies are actually doing something.
Right. And then you brought up something really interesting at the end, that most people, they may heal on their own, or they seek treatments and they feel better from their symptoms, but they never actually healed their brain injury. And then that can be exacerbated later in life. For example, if you catch influenza or COVID, then that can be more exacerbated later in life. For people who come in and they're not coming in specifically for a concussion, let's say they're coming in for neck pain, but they've had a concussion previously, would you still run these same tests to understand how that concussion is impacting them, whether it was 2 years ago or yesterday, and how it's impacting their current case presentation?
Without a doubt, we run the same test on everybody, whether they have a concussion or not. And at the end of the day, these are our biomarkers for our clinic that represent functional metrics to allow us to understand how you're performing in life. Right. And so just like if you want to go to the NFL, you're going to be sitting at a combine and they're going to do all these tests to say, what caliber of human are you in football? We do the same thing to every patient. So we have no unique testing for concussion. We test brains. Right. And even if I don't know you had a concussion, I could find things that I see that usually are correlated with concussions, but it may not be a concussion. You might have the same area of the brain that was injured for something else. Maybe it was a virus or whatever it is. But so it really comes down to not necessarily saying this is what caused it per se, because that's more history and other aspects of it. It's more understanding that all behavior is a representation of brain function.
Yes.
And what I want to do is assess behavior and get a view of the brain function underneath that, and have an idea if that's a normal brain function for your behavior or abnormal. And then what really I want to do is try to correct that underlying brain function to create normalcy for you, to allow you to live your life, because concussions a lot of times impact connectivity. And, the connections that you have now might work for you at 10 or 20 or 30 years old, but another 10 or 20 years of life, all of a sudden those connections might start breaking down and you have less connections to spare. Right. And so when you look at the future of the brain, it's much more like connectivity than it is about inflammation. And inflammation can affect connectivity, and inflammation is not good. And inflammation is associated with tons of conditions, but it's associated with these things, right? And when you look at connectivity, that's the future of medicine, is changing brain connectivity to change function and structure of the brain. And that's where the whole world is moving to a while ago, but it takes a while. And so by 2030, you're going to see it more as technology gets better. Now you see us scratching the surface with some things, but the future for mood disorders, especially depression, anxiety, for concussions, for pain disorders, is all neuromodulation.
Nice. The future for healthcare is connectivity. You heard it here. Well, as we wrap up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Traster for his excellent work in the field of functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host on the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.